Okay. Good afternoon, everyone. Thank you for joining us for our virtual town hall on birth equity during the COVID-19 pandemic. My name is Dr. Mutal, and I am an associate professor at Tufts University in the School of Medicine. And I'm also a proud member of the Massachusetts COVID-19 Maternal Equity Coalition and the Penguin Board. And on behalf of both of those organizations, as well as the Betsy Lehman Center, we want to welcome you to our event today. So I'm thrilled to be here today as we center birthing people and really highlight the experiences of birthing people that have given birth during the pandemic. And we have a few key questions that we'd like to answer today. And so we'll be engaging all of you in the chat. And so I would just encourage all of you to use the chat feature now by typing in your name and your affiliation, and let's start to build a rapport in the next 90 minutes that we have together. Our first question is, what was it like to give birth during the pandemic? What aspects of care worked really well? And what aspects of those care should we continue to keep as we move forward in our new normal? And then what aspects of care were actually made worse by the pandemic? And how do we learn from this and rebound once things return to a new normal? So through today's virtual event, we'll be asking the audience questions and keeping you all engaged. And I think this is an opportunity for us to really have a candid conversation about what the status of birth care and birthing equity looks like for Massachusetts. And at this time, I'd like to go ahead and introduce our first speaker, who needs no introduction, Dr. Jalisa Jali, who is the director of the Division of Maternal and Child Health Research at the Massachusetts Department of Public Health. She's had a long and distinguished career and really works in the field of maternal child health to further policy, to affect change. And she's here today on behalf of Secretary Sutters to talk to us about the administration's and the Commonwealth's response to vaccine equity. So with that, I'm going to turn it over to Dr. Jali. Thank you so much.
Thank you so much, Dr. Mutal. Good afternoon, everyone. It is my pleasure to welcome you all to this town hall on behalf of Secretary Sutters, who unfortunately could not join us today. I thank you all for being here to take part in this important discussion. We are pleased to partner with you on creating healthier and equitable communities. The focus of this town hall, birth equity during COVID-19, could not be more timely to raise awareness about the need to work together to create more equitable communities as both pandemics, COVID-19 and systemic racism continue to intersect and challenge the communities of colors across Massachusetts and the rest of the country. At the Mass Department of Public Health, we place equity at the core of everything we do. COVID-19 has not impacted us equally. It has revealed the historical and current inequities in our society, particularly among communities of color, low-income populations, and people living with disabilities. This is also true for those experiencing homelessness, housing insecurity, food insecurity, living in nursing homes and care facilities, and those who are incarcerated. Due to underinvestment and lack of opportunity, communities of color suffered the long-term health consequences of systemic racism. Hence, they have also experienced disproportionate impacts related to COVID-19. The more we can uncover about these inequities, the more we can center our actions around them. To that end, we convened the COVID-19 Health Equity Advisory Group, which included 26 community leaders, health and racial equity experts, and members of communities and populations disproportionately impacted by the coronavirus pandemic. The advisory group informed the state's COVID response by recommending actions aimed at equitable access to healthcare resources and services and prevention of inequities in outcomes. When we authentically collaborate with communities, we work together to not only inform, consult, and involve, but to move toward empowerment, community-driven efforts, and closer to advancing health equity and improving quality. Through the pandemic, statewide services offered to support pregnant people and families with young children have continued. These include programs such as WIC, the Nutritional Supplemental Program for Women, Infants, and Children, which provides healthy food, nutrition education, breastfeeding support, referral to pregnant and lactating people and children from birth to age 5. WIC serves a higher percentage of families of color, many of whom have been among the most vulnerable to COVID-19. WIC also provided virtual group support and education to women, both prenatally and postpartum, to promote longer breastfeeding duration, which is extremely important and healthy for the newborns. In addition to WIC, the Massachusetts Infant and Early Childhood Home Visiting Programs, which provide a range of home visiting services to families in selected communities, continue to provide visits through both remote and in-person, including screenings for both depression and social connectedness, and make referrals to services as needed. Recognizing the many challenges faced by people with substance use disorder, particularly pregnant people, we've been working diligently to keep all the Bureau of Substance Addiction Services, BSAS license, and contracted programs open and accept new patients during the time of COVID. In October 2020, we implemented the Pregnancy Risk Assessment Monitoring System, known as PRAMS, COVID survey to better understand experiences, attitudes, and behaviors of people who gave birth during the pandemic. We are currently implementing another survey focused on COVID-19 vaccine, which started in April. PRAMS offers a unique opportunity to understand experiences of new parents at the population level because it oversamples people of color to maximize their participation in the survey, and specifically asks about racism using validated questions. Findings from the PRAMS survey will be shared later this year with providers and other state maternal health organizations. The Massachusetts Department of Public Health is also implementing the CDC COVID-19 pregnancy surveillance through the Surveillance for Emerging Threats to Mothers and Babies Network, known as a SETNet, a surveillance system to collect supplemental information on pregnant women with laboratory evidence of COVID-19 and their neonates to rapidly identify the impact of emerging health threats to pregnant people and their infants. A new state commission established under a law Governor Charlie Baker signed in January is tasked with seeking out steps to address racial inequities in maternal health. The 27-member commission will have until March 22 to file a report with recommendations and any draft legislations to reduce or eliminate inequities in maternal mortality and severe maternal morbidity, and investigate the challenges to accessing prenatal and postpartum care, the availability of doulas and birthing centers, and the impact of historical and current structural and institutional and individual forms of racism. In March 2021, Mass Health proposed to provide 12 months postpartum coverage regardless of immigration status to individuals with income up to 200% federal poverty level. This extension of coverage will significantly improve access to healthcare and continuity of care, particularly in the vulnerable period after childbirth, while reducing inequities in health outcomes. Mass Health is also developing a policy to cover doula services as part of their efforts to address racial inequities. Working with the Massachusetts Perinatal-Neonatal Quality Improvement Network, known as PINQUIN, a statewide organization recognized in Massachusetts and nationally as a leader in quality improvement that promotes maternal and neonatal health while centering equity. PINQUIN has built a patient and community engagement network to inform perinatal services and care. Through funding provided by the Department of Public Health, PINQUIN is providing stigma and explicit and implicit bias training to nurses and other providers across the state. Through a CDC grant, PINQUIN will utilize existing stakeholder and educational platforms to build greater educational resources to improve provider capacity, protocol implementation, and clinical community care linkages for equitable delivery of SARS-CoV-2 vaccination to pregnant and lactating people and their families. Transitioning now to vaccination. Massachusetts is a leader in vaccination administration. More than 3.5 million Mass residents are fully vaccinated, and around 4 million people, representing 77% adults, have received at least one dose of the vaccine. Youth ages 12 to 15 are now eligible for the Pfizer vaccine, which is being administered in multiple settings. The three pillars of our vaccine efforts are to preserve life, preserve our healthcare system, and promote health equity. To inform our vaccine deployment efforts, the Massachusetts Department of Public Health conducted a community impact survey in 2020. And in February 2021, we launched our Vaccine Equity, a community-centered initiative. The goals of the community equity initiatives are: one, to increase the trust in the vaccine's safety and efficacy, acknowledge that in many communities of color, mistrust and hesitancy can stem from a historical of medical mistreatment. Two, to identify and reduce barriers in communities for accessing the vaccine for those who are eligible and ready to receive the vaccine. And three, to facilitate strategic allocation to priority populations through existing sites, as well as leveraging mobile vaccine options. Using the CDC Social Vulnerability Index, as well as case rates of COVID-19 in communities, we have identified and prioritized 20 high-need communities in Massachusetts. Staff from MDPH have volunteered to serve as community liaisons and are doing an incredible job to support grassroots outreach efforts. Now, a little bit about vaccination in pregnancy. National COVID-19 case surveillance data have shown an increased risk of severe disease and death among pregnant people with COVID-19 compared to non-pregnant people with COVID-19. Existing data do not demonstrate any safety concerns of vaccination against COVID-19 during pregnancy and lactation. There are limited data regarding the safety and efficacy in pregnant and lactating people of the COVID-19 vaccines that are currently available in the US, as pregnant and lactating individuals were excluded from the original trials. However, data regarding immunogenicity and reactogenicity are starting to surface from cohort studies in pregnant and lactating people, predominantly healthcare workers who have decided to receive the vaccine. In a recent study at 2 Boston institutions, immune response generated after mRNA vaccines was comparable in pregnant and non-pregnant individuals, and higher than in pregnant individuals after a natural COVID infection, suggesting efficacy of vaccination during pregnancy. Antibody titers were also detectable in umbilical cord and breast milk, indicating that neonatal immunity may be acquired through maternal vaccination. In theory, the mRNA vaccines are safe during pregnancy. They do not carry live virus and therefore would not be expected to increase harm to the fetus. Vaccine safety data are limited, though based on the inadvertent pregnancies that have occurred in the main trials, there is no signal that adverse pregnancy outcomes are increased in the small number of pregnant people who have received the vaccines. Of the 35,000 pregnant people enrolled in the CDC V-Safe vaccine program, 3,900 have been followed longitudinally with 827 completed pregnancies. Adverse pregnancy outcomes in this cohort were within the expected range for unexposed pregnancies. Side effects were also similar to the non-pregnant population. Given the growing but limited evidence regarding the vaccine efficacy and safety in pregnant and lactating people, guidance on vaccination counseling from professional societies is evolving. The CDC states that pregnant persons are eligible for and can receive the COVID vaccine. The American College of Gynecology and the Society for Maternal Fetal Medicine state that vaccination should be made available during pregnancy and encourage a shared decision-making model, balancing theoretical risk of the vaccine with the risk of moderate or severe disease from COVID for individuals' risk profile. While prenatal providers are in a unique position to help guide the patient through the decision-making process for the vaccine, one of the traditional barriers to vaccination is vaccine hesitancy, driven by the lack of confidence in vaccine safety, as well as the historical context that makes certain communities less likely to have trust in healthcare recommendations. A survey of pregnant people and parents of young children across 16 countries reported that the strongest predictor of COVID vaccine acceptance included confidence in the vaccine safety and effectiveness, perceived risk of COVID disease, belief in the importance of the vaccine within the cultural context, and trust of public health agencies and healthcare and health science. In closing, your work ahead lies in listening to and honoring community members and grasping the root of what really generates health outcomes, like residential, racial, and socioeconomic segregations, which limits access to opportunity, and how city planning, education, housing, employment, and income are often intertwined within systems that demand a large-scale change to meet those large-scale injustices. We can keep applying temporary solutions to the same old problems, or we can decide we're going to fix them, the underlying conditions. We should no longer accept conditions that create health inequities. We will work together to create communities in Massachusetts where the healthy choice is an easy and possible choice. I want to thank the organizers for inviting us today. I hope you enjoy the rest of the town hall. A lot of great information and discussion is coming your way. Thank you.
Wonderful. Thank you so much, Dr. Job, for that riveting presentation on behalf of MDPH and Secretary Sutters. Before we move to a series of short presentations by birthing people that have given birth during the pandemic, I want to pose a question to the audience, and it'd be great if we could get a response in the chat. Dr. Job raised a lot of interesting facts around vaccine hesitancy and what's happening currently for vaccines for pregnant and postpartum people. And I just wanted to know, are there concerns among people in this chat today around getting vaccine for pregnant and postpartum people, and what are those concerns? So let's start a conversation around that in the chat and see what we can generate. In the meantime, I'm thrilled to announce our first speaker in this short line of speakers. We pre-selected people based on their responses in the survey, really with the focus of centering birthing people during the pandemic. And our first speaker in this lineup is Dr. Jalisa Jali. Thank you so much.
Thank you so much. It is really great to be here with all of you. And thank you for creating space for all of us birthers, Black and Brown birthers, to share our experience. I want to say that I'll start out by saying that, there's a very unique experience to birthing while Black in COVID-19, and it really means trying your best to focus on life while the world is surrounded by death and chaos. And I think collectively what my experience really, I hope people understand from is clinicians have to hold each other accountable and be strategic about how we disrupt very dehumanizing clinical practice while we're honest with each other about how racism shows up in our living, working, and birthing spaces. And so I gave birth back in February, and I think one of the threads that I see from this moment was just kind of like how the dismissal of self-advocacy was really heightened, especially in the name of like public health guidelines. And it was a very contentious sort of way of balancing the need to protect these guidelines and implement them, but also like honoring and creating wholesome experiences for birthers. That was collectively really difficult. And it often worked in a way that trickled down to really negatively impact birthers like me. So for example, my husband and I got to the hospital at 7 a.m. By the night, late evening, my labor process was full under swing. My induction process was full under swing. My husband began throwing up, and the nurse that was actually not attending to us at the time, but someone outdoors heard him and asked him to leave the hospital. No questions, no curious explanation, nothing. They just said, "Hi, mama," and they requested that my husband leave the hospital. And they asked me if I have another support person. I noted that my mom is in New York City. I'm in Springfield, Massachusetts. Mom might not get here in time for baby to be born or to support me through that process. But they mentioned, like, I mentioned to them that I have a strong desire to have the father of my child present at this special moment. And my husband at the time noted that he recently received a negative COVID-19 test before we entered the hospital. But the nurse at the time was really unwilling to listen, and the folks in the room kind of just watched and looked on. And I think most of the time she spent rebutting my request and not really thoroughly listening to exactly what my needs were. So I really had to break it down, right? So everyone in the room would have a deeper understanding of what it really meant to create wholesome birthing experiences for people, especially women of color in this time. And as my Pitocin level increased, and as I laid on my back with a balloon inside of me, I had to explain the pre-existing inequities in Black maternal mortality. I had to really assert my desire to not become another statistic. I had to sort of really cite the fact that labor support is crucial in Black maternal health outcomes and in the maternal health outcomes of women of color more broadly. And I really repeated my request to access more options before dismissing the importance of my partner's presence. Again, the people in the room looked on, and one of the people in the room was the nurse manager, who kind of requested that my husband be tested on site instead of driving around the city of Springfield looking for testing. My husband received a negative COVID test, and he was able to join me later on in that room, and I felt so much better. So I just want to reiterate this refusal to kind of listen to patients, right? Is the sort of condescending behaviors. As I advocated for myself, the nurse who was requesting that my husband leave, laughed at me. She later suggested that my husband, that I name my daughter after her. And so when I think about these, there's more than just someone having a bad day, or it's more than just, one bad apple. And it's more than just kind of a poor, bad joke. It's the very processes that devalue and fail to honor certain bodies. And they're so ingrained in the way care is given that we don't always think intentionally about how they're distributed and how it is given. Exactly. Cumulative deprioritization is a huge thing. And finally, in closing, I just wanted to mention that there's another sort of defining experience is when I was getting my epidural administered to me. I requested informed consent, and so did my nurse. And at the time, the anesthesiologist continued he said, "I'll explain as I go on," right? And he seemed really impatient, was really rushed, and I started getting really nervous and just felt devalued in the whole process. And I think I started thinking about the people who recently died in birth, and I thought, wow, I wish I would just have the process explained to me in a way that was clear and patient. And I think that itself further sort of clarified many of the themes that I already stated. Is just kind of not just a dismissal of self-advocacy in this context, but the lack of really informed consent. My nurse demanded that he stop because my anxiety was really expanding, and they invited another anesthesiologist who explained the process and was really patient. And so to kind of wrap up, when I'm thinking about the aspects of care that were better during the pandemic, right? I named a few things that were not so good. But one of the aspects of care that I think were better was there was an intent to reflect on the care that practitioners give. And I noticed this because the nurse managers afterwards came to my room and kind of apologized for not speaking up, which I think is something very important to point out. I have friends who are clinicians, and one of the things that they say is their colleagues are going to continue doing dehumanizing things anyway. And I think we have to be intentional about disrupting that. And to wrap up, I'll say the fact that I gave birth on the heels of a massive racial uprising that during a time where our nation was reckoning with institutional discrimination and systemic racism in all of its forms, I think there was a way in which there was a conversation, or at least mindsets that were thinking about how do we think about shared decision-making, prioritizing Black and Brown birthers' desires in institutional cultures and structures and interpersonal encounters that have historically devalued them, right? How do we do this, especially as we know that a predominantly white medical staff is often not trained in specialized knowledge about working with communities of color and diverse populations. So I think this is incredibly important for us to think about accountability, being strategic about how we're disrupting these dehumanizing clinical practices so we can create more wholesome experiences for all women, especially Black women and women of color who have historically been treated in dehumanizing ways.
Thank you, Dr. Jali. You're getting a lot of love in the chat as well. So thank you for sharing that beautiful story. I'm going to transition us now to our next speaker, Dr. Viveka Prakash Zawiza, and she'll present her birthing story. Thank you.
Thank you so much. Thank you, Dr. Jali, for sharing that story. As a clinician, it's important for me to hear those stories and to be held accountable in the way that you called out. And so I just wanted to acknowledge that. Thank you so much also for giving me this opportunity to be here. I want to acknowledge, even though I am a brown woman, I enjoy many privileges within the healthcare space. And I'm going to highlight those because I'd like to share something that happened in my postpartum experience that happened despite my privileges, and really drove home to me that if something like that could happen to me, I can't even imagine what's happening to people who aren't in my position. So I'm a practicing OBGYN. I am very well versed in the labor and the birth space. This was my second child. I have a 3-year-old daughter who I delivered, pre-pandemic, had a wonderful birth experience with her. So this, in a sense, I consider that a bit of a privilege as well, that I wasn't navigating my first pregnancy and a first birthing experience in the midst of a pandemic. Additionally, my provider, my OBGYN, because I'm in the field, she's actually a friend of mine, and she's someone who I was able to choose to work with, knowing very intimately what her practices were. I also gave birth in a hospital where I used to work. So I knew the staff, I knew the nurses, I was familiar with the layout of the floor, I was familiar with the medical lingo. So again, I'm highlighting to you these very, sort of privileged positions that I was in. My birth experience actually was fine. Again, being my second child, I arrived at the hospital when my labor was already fairly advanced, and was able to have a very smooth delivery process. And even postpartum in the hospital, things were pretty good. And then went home, everything, thank God, was fine. What happened that was really troubling happened at my 6-week postpartum visit in my provider's office. I had made the appointment, as many of you know, it's a routine 6-week checkup after a vaginal delivery. And I decided to bring my baby with me because my OB hadn't been available for the birth, and I thought she would want to meet my baby. So, and this is a very common practice. Any of you who work in the postpartum space know that women often bring their newborns with them, especially my son being exclusively breastfed. I wanted him with me. I arrived at my doctor's office, and my baby does not like the car seat, so he was screaming his head off. And so I was really looking forward to bringing him inside, taking him out of his car seat, maybe nursing him, soothing him. I got inside the office, and instead of a warm welcome, the receptionist immediately said, is there someone else here who can take your baby? And I said, no, I'm by myself. And she said, well, he can't be here. And I was a little taken aback, and I said, I don't understand. And then both my doctor and one of the nurses came out into the waiting room, and the nurse took my baby from me without explaining what was happening, without asking my permission, took the car seat and walked out of the office. I knew this nurse, so that again, at least was a mitigating factor. This wasn't a stranger, but as you can imagine, being separated from my newborn like that was really scary. I started crying. My doctor quickly sort of took me into the exam room and, was like, "Oh, I'm so sorry. It's the policy. We can't have visitors." And I said, "Okay, he's my newborn baby. He's not a visitor." And she said, I know, but we have to, if someone sees you with a baby, they're going to want to bring their babies. And the whole thing was just pretty horrifying. And actually that is my baby crying in the background, but my husband's looking after him. So anyway, the visit took place. It was fine. Of course, I was totally rattled. I don't think I even remember what happened. I requested an IUD, which she placed. I don't even remember that happening because I was so shaken up. And, the visit concluded and the nurse was in the hallway with my baby and he had calmed down and, we went home. But it didn't hit me until later that evening when I was telling my husband what had happened and that I was like shaking and crying. And I realized how this was a truly traumatizing experience that I'd been through. And I was so, I trust my doctor. I, again, highlighted for you all the different ways in which I was in such a privileged position, and yet this still happened to me. And I was able to give my doctor feedback on this, and I told her exactly how I felt about all this happening. Luckily, she was receptive. I gave a very, very obvious solution, which is perhaps you should be telling your postpartum patients that they can't bring their babies with them. No one told me that. I wouldn't have brought him if I had known. I would have arranged something else. So anyway, she said that she would take that and make that her new office policy. So I, again, reflecting on this, I was able to have that conversation with my provider. We were able to sort of come to some sort of a resolution around it. But even now, talking to all of you, I feel lucky. I know so many of you. I consider so many of you my dear friends. So I feel safe sharing this story with you. But even thinking about this still, gets my heart pounding. I still feel very upset. And this happened, my son is, 14 weeks old now. And it's still a very upsetting recollection of mine. So to me, this highlights something that we really lost during the COVID pandemic, which is the ability to be compassionate and to think critically about these guidelines. I understand the visitor policy. I don't understand that that extends to a newborn exclusively breastfed baby. So I think having that space for some critical, thinking and using some common sense, similar to Dr. Jali's story, listen to people and, like just take the whole picture here and not just, stick to the guidelines for as if they're set in stone. And, I think I opened my eyes to how we communicate, how we prepare people. And, yes, the pandemic is a serious event that's ongoing and with a tremendous loss of life, but we can't lose our compassion as a result of it. So thank you again for giving me the space to share this story. And, I'm okay. I'm doing all right. And I'm actually very happy I was able to share this with all of you. And I hope that those of you who are in spaces providing care, to people who are pregnant and postpartum and enforcing COVID guidelines will at least keep this anecdote in mind, and just try to look past the guideline and see the person in front of you and just think about what's happening. So thank you so much.
Thank you, Dr. Viveka. Like, how is that policy that a newborn can't? That is so ridiculous to me. That is crazy. I agree with you that we've lost compassion during this process. That's why I said just be a human being, right? Like, I mean, just think about it and put yourself in this new mom situation. And as Lisa rightfully pointed out in the chat, it is a privilege to be able to have childcare, to arrange for somebody to take care of your child, particularly at that critical juncture at 6 weeks old. So thank you for sharing your story. So before I introduce our next speaker, Dr. Pooja, I wanted to just pose a question to you all in the chat. And this is a little bit reflective and kind of builds on my first question around vaccine hesitancy. What is your top concern during the pandemic around prenatal care and birth in Massachusetts? What are top concerns that you all share? So please go ahead and put that in the chat, and just let us know what you're thinking about. What are your concerns? You've heard two really poignant personal birth experiences so far. So use that as a point of reflection for your own thinking about what are some of the top concerns that you may have. And with that, Dr. Pooja, you have the floor. Thank you.
Hi, everyone. Thank you so much for having me. And I'm going to continue the theme of speaking as an obstetrician and a quality expert and also a health equity advocate, but now speaking mostly as a birthing person during COVID. I'm a little nervous. I'm going to read, so you're going to see my eyes going to my notes here, but thank you again for this opportunity. I also carry so much privilege in birthing spaces. At the beginning of this pandemic, I was working full-time for City Block Health, creating systems of care to support our low-income patients who were slammed with this infection in Brooklyn, New York. This involved telehealth visits across state lines and frantic calls to ICUs to help families say goodbye to loved ones and negotiate critical care in Brooklyn. But I was also working as an OBGYN on a labor and delivery unit in New Orleans at the beginning of this pandemic. And I truly could not have imagined that just weeks after taking care of our first critically ill pregnant and postpartum patients with COVID, I would be pregnant. So when I reflect on all of it now, and I also want to use this opportunity to advance a positive vision, a vision that we can work towards and scale together. So many aspects of my care once arriving here in Boston were deeply humanizing and healing, particularly because they happened during this pandemic. I think of my doula, who is on this call, so shout out to Abere, who visited my home, who stood in line in the community to test herself for COVID so that she could safely accompany me through the third trimester of this pregnancy, virtually, in person, on text message, and who was there at my bedside during my hospitalization because of the permissive policy on labor and delivery where I gave birth. Yes, I have support. I have people on the other side of the cell phone, but I needed that person there to remind me that it was okay to protect my privacy, to trust my team, to take my time when the system kind of went into its automatic hustling forward mode and I felt left behind. And I needed that person there to help me feel not just safe and okay, but also joyful and connected. And affirming joy and affirming connection during this pandemic moment is so important for Black and Brown birthing people. And there are systems that we can build affirmatively to create that feeling for all of us, not just those of us with the most privilege. I think of my midwifery care that I received during this pregnancy by a midwife who knew me before I was pregnant, and how important it was to have that privilege, which is just not available to most people who give birth in this country, as a quote unquote normal birthing person, but also the former director of a maternal mortality review program. With all of these stories and experiences in my mind, I really needed to be seen as my whole self during this pregnancy. And I really needed to be reminded every single day of what is normal and natural and life-giving about pregnancy, to not be afraid. And the midwife who cared for me knew about my history of sexual assault. She knew about my history of anxiety. She knew about intergenerational issues in my family and my personal journey to the choice to become pregnant. And I just reflect so much on what a luxury that is. And also so within reach at a systems level for the people that we care for and are here for today. This is a privilege that is within reach that we can create space for all of us. When my labor and delivery course teetered on the boundary between quote unquote low and high risk, an on-call obstetrician that was a Black provider who also deeply understood my goals and my fears was available. She was hovering outside our door in the hallway. She didn't break the space. I was there with my partner and my midwife and my doula, but there was this safety outside ready to support us in a seamless transition if that was needed. And this seamless partnership and care, I know with my PQC hat on, is so evasive at a systems level, but also so critical to my eventual outcome of a safe vaginal birth. This is the standard that should be accessible across the state of Massachusetts and nationally, to have midwifery care in collaboration with interdisciplinary teams. So here's this positive vision and, not but and, layers of my experience as a birthing person also remind me that even with the privilege of a healthcare professional with training and quality and policy and research, There were things that could have been better about my experience and things that we can improve together related to the historical fragmentation of these systems and a maladaptive design that, was not meant for all of us. For instance, I remember a very numb feeling of shock when during a testing appointment in response to me sharing that I thought my blood pressures were trending up during my pregnancy in the 3rd trimester. A provider who was not longitudinally involved in my care told me that I should not be checking my own blood pressures at home, as I probably did not know how to measure my blood pressure correctly. Even after my prenatal provider had given me this blood pressure machine, moved half of my prenatal appointments to telehealth only appointments, which were really, a couple of minute phone calls. The person who said this to me knew I was a physician, was someone who knew me. By the way, my insurance company declined to pay for that blood pressure machine, which just goes to show that this move towards telehealth during COVID pandemic is really patchy and really challenging to know when it's sufficient for people with different health literacies. And of course, as I was in this healthcare moment where this person was telling me that, I shouldn't be paying attention to this number, that my blood pressure was trending up, I left that wondering for days and for months, as thousands and thousands of people do, and we know this, whether that would have happened if she was not white and I was not me. And regardless of the truth of whatever it was, my truth is that I had to wonder why I was being disbelieved in that moment. And I didn't necessarily need to be reminded of that, but living that feeling as a brown person working against anti-Black racism in our system, living that feeling and feeling it in every sort of piece of my body during the pregnancy, man, that was intense. And I hope that we can continue working together to expose and understand and debride whatever that is, whatever that questioning is about when it's put on birthing people. I identify as queer, and over the course of being pregnant, I reconcile myself to the fact that my discomfort with the gendering of my baby and the gendering of my body and the use of the words mommy and mama and other words simply would need to go unstated. It always fueled my desire to stay out of the system and to solve my symptoms and physical experience somewhere else when possible. I think about people who don't have the privilege that I have and how that must feel, particularly during COVID, particularly in cities where people may not want to ride on public transport looking pregnant. What can we do about that? How do we change the framing of this care? I'm going to finish soon, sorry, but the decision to get vaccinated or not, the decision to get tested or not, seeking those things outside of my pregnancy care, standing in lines at community sites, we don't have a system that integrates well with these additional needs. And I appreciate Fifi speaking to this at the beginning of this town hall. And just lastly, something I hesitate to share, but I'm going to share anyway, given that all of you are my professional community and colleagues and friends. I struggled with worsening anxiety throughout this pregnancy, as many people are right now. I imagined all of the complications that I had been bearing witness to as an OB happening to me at each successive stage of this pregnancy. And once diagnosed formally with depression and anxiety of the pregnancy, it took weeks to integrate the necessary care into my prenatal care, even with all of my privilege. Even knowing the system so well, knowing every nook and cranny of the hospital where I gave birth. And this was during the very pandemic that was impacting my symptoms and a deep sense of isolation. And I'm still struggling to deal with a bill for thousands of dollars for a 7-minute phone consultation with a psychiatrist during my pregnancy. How are other folks dealing with this? I have so much knowledge, and that's what got me through. And I still felt this deep sense of shame talking about these diagnoses, showing up on L&D with these diagnoses in my chart and with the medication in my record. We know that not talking about this isn't going to help any of us do our job, and we know that we can do better. We know that the pandemic is a portal. It's reminded us of the importance of integrated behavioral health. For those with fewer resources and less privilege than me, doing better is really a matter of life or death, and I've spent my career studying that. We need easily accessible, community-based behavioral health care that's integrated into pregnancy and postpartum care with all of the insurance barriers minimized. So I'll stop there. My baby's name it means wind and breath. And at a time when so many have not been able to breathe because of uncontrolled infection, because of state-sanctioned violence, because of oppressive systems and a lack of leadership, Baby Vayu has joined us, and he's my daily reminder that we can build better worlds that give us all space to center and breathe and let go of shame. And I hope we can ride these winds of change together and look forward to hearing what everyone else has to say. Thanks.
Thank you, Dr. Pooja, for your beautiful story and for sharing. Yes, Pooja, you are loved. Lots of love in the chat for you. I have another audience engagement question here. How many of you have experienced great care recently or really quality care? And what did that look like? What were the components of that that really kind of stood out for you? I think that's kind of another point of reflection in this process. And the reason we're here today is, one, to hear the birthing experiences of people that have given birth during the pandemic, but also to think about the ways the system can be improved and what are the parts that we really need to focus on moving forward. And so I'll ask that in the question in the chat in a minute. So that's kind of where we are. The floor is open. We definitely welcome questions. We welcome additional stories. I want to thank all of our speakers who shared their beautiful personal stories and are here in their strength and beauty. And I just want to really lift all of you up and hug all of you. And so the floor is open. We have a good amount of time left. I'm happy to take any stories from the floor, any points of reflection. If participants need to raise your hand, please use that feature in Zoom. You can raise your hand by opening the participants tab bar on your screen and then clicking to the raise hand. And then we can open the floor to anyone who wishes to either share their birthing story and or ask questions of everyone here. Okay. And our Zoom host, Natalia, will be unmuting participants so we can allow for discussion. Thanks.
If anyone does want to share, they have the ability to unmute themselves, but if you're struggling, I'm more than happy to assist.
So I know we have a lot of providers here representing different clinical practices across the state. Does anyone want to share some of the things that they think are working really well on their L&D floors or in their settings that you feel is something that you can be proud of as a provider during this pandemic? We definitely want to hear both sides of the story. So happy to answer any questions or to pose questions to our amazing speakers today. Any providers want to start? Chloe, I see you have your hand up. Can you unmute yourself?
Yeah, I apologize. I was joyfully attending births in the middle of the night, so I'm in recovery mode. But I think this notion of like what is important to somebody's birth experience is an active conversation on our labor and delivery unit in the wake of COVID. Like what I think the initial restrictions were really painful and difficult as providers. And we had to wrestle with what that meant and what our role was in advocating. And I would say that, like, at least for my circle, I've found that what this has done is really accelerate the conversation about equity in many ways, like, but really has prompted a whole lot of soul searching. And I think, you know, it's coincided with increased awareness of disparities in maternal mortality and maternal outcomes in general. But I think that it really, there's a palpable culture shift, and that's one of the silver linings, if there are any to be had in this situation, is that the conversation is very much out in the open and coming from not just like the usual suspects of those of us who've been trying to move the conversation, but also people who are asking genuine questions and wanting to learn. And I think we've had a lot of really moving conversations and people seeing their patients and seeing their role in this experience and facilitating it. So I think that doesn't mean we're doing it right by any stretch. And I'm just so grateful to all of you for sharing your experiences, because I think as a provider, it's incredibly difficult and important to hear these and know how something that we maybe don't give enough thought to can make such a huge difference. But at least in my institution, I do feel like there's been a sea change in terms of the number of people talking about how we incorporate equity into everything we do and every policy we make, and how we really need to build it into the structure of what we do.
Thank you, Chloe. Anything else? Personally have heard a lot that I want to take back to the research spaces that I'm in, and I'm so glad so many of my amazing colleagues and investigators are on the phone. Dr. Job, Dr. Meadows, these are all parts of the conversation that we should be centering in the work that we're doing, that we have the privilege of doing. And thank you to all of our amazing hospital partners who are engaging in that work with us as well in our R01. I see a hand from Sarah. Are you able to unmute yourself?
I am, thank you.
Sure.
I was typing this whole long paragraph into the chat, and then I said, you know what, let me just say it. And at the risk of upsetting any of the clinicians on the call, I'm kind of coming at this from a my doula hat perspective. I think for me, just witnessing our birthing families, just the insane variance in policy across hospitals in Massachusetts. You know, in one hospital, you're allowed to bring a support person plus your doula. At another hospital, you're not. At one hospital, you might be separated from your newborn. At another one, you may not. And just the inequity, and not that these inequities didn't exist prior to COVID, but I think COVID certainly exacerbated them. And I was just thinking, it made me think of Dr. Monica McLemore's piece, which I don't know if anyone here is familiar, but highly recommend. She says, COVID-19 is no reason to abandon pregnant people. And to me, I just think a lot about, you know, there's going to be more pandemics, there's going to be emergencies, and there's going to be excuses that can be used to, you know, take away pregnant and birthing people's rights to have continuous labor support and high quality care. And I guess I'm just thinking a lot about post-COVID, how do we ensure that what we've seen, the trauma that's been caused by the way the medical and maternity care system has responded, that doesn't happen again in the future. And also taking it as an opportunity to look at how inequitable care is, you know, the inequities in care delivery and policies across the state, and how, you know, a person delivering at one hospital may be treated a totally different way policy-wise than another. I don't have any solutions, just questions.
Yeah, thank you for that, Sarah. And I always enjoy your questions in these spaces, because I think you bring that perspective. And I think that's really the crux of why the Massachusetts COVID-19 Maternal Equity Coalition was founded. That's really one of our charges as a group, is to kind of question this and to address it in the best way we know how. And we put out a series of policy recommendations, and we're trying to do the best we can to kind of standardize this process across the state. And we've heard so many of these critical stories from birthing people across the state about how each hospital practice is different. And I think the more that we continue to elevate this conversation, and the more that we continue to hold ourselves and the systems accountable, then we can start to move this needle forward. And I'm encouraged by spaces like this right now, because I think this is a conversation that needs to be had. So thank you for saying that. Dr. Jali, I see your hand is up. Thanks.
Yes, I just wanted to echo and say thank you to my co-panelists. And I just wanted to sort of ask other people in the room if they have any sort of models for what these interventions can look like. For example, like Pooja, I really appreciated you talking about kind of like the importance of like systems level and making sort of partnership, like midwife care in collaboration with these interdisciplinary teams of really targeted and tailored way to sort of intervene. And I think that sounds like creative and totally doable. And I just wanted to know, you know, is there space for it as we're thinking about like this integration and we're thinking about these sort of collaborative teams, is there space for like community organizations or community stakeholders, right? Especially getting involved beforehand, especially as we know that many Black and Brown birthers usually typically access a lot of the times perhaps community spaces for care or for other services. And don't always feel comfortable in the medical sphere until perhaps later on in the journey. So that's just one question. Is there like, what do others think about the space of like, you know, engaging community leaders, liaisons, and organizations? And then the final thing I just wanted to say thank you for mentioning is Pooja is like this need to sort of put the maternal mental health into these conversations and to sort of interweave the medical sphere with the sort of maternal mental health part, not in a way that incorporates in state structures that are already dehumanizing and invested in separating family and kinship networks, but in ways that really intentionally prioritize the holistic person and being, yeah. So just some thoughts and questions.
Great. Thank you, Dr. Jali. Anyone want to chime in? I just posed the same question in the chat. Are there successful models that people have heard of, have implemented in their own clinical settings, or have read about in research settings that we can begin to utilize and adapt here in the Commonwealth? I'm doing a quick, sure. Somebody was going to say something.
Yeah, I don't know that successful is probably the right word to use for it, but I do think that navigating the systems that we had, considering the, you know, the lack of knowledge that we had really at the onset. I want to say that here at Lowell General Hospital, I think we partnered with our hospitalist that we had, tried to really meet our patients where they were because everybody has different circumstances, tried to accommodate when appropriate. And I think back, we were probably one of the first hospitals that said we were going to do shared decision making, especially whenever it came to the determination of whether a family was going to keep their baby with them or be separated. And it talk about the common sense approach. It didn't make sense to us, in all honesty, if we were going to say to a family, you have to be separated from your baby at time of delivery, only for us to hand the baby over to them on day 2 of life to go home with them. And so we wanted to take the opportunity to actually use that as an educational time frame. It's almost like anyone else. You know, we don't separate moms if they have flu. However, we try to educate them on how to safely take care of their baby during that time frame and how to reduce the risk of exposure and reduce that risk. And those are all of the things that were happening out in our community as well. We have the honor, honestly, of taking care of a really diverse, broad group of women who have come from different backgrounds, who come from different countries, different languages. And so I would say success is maybe a strong word to use here, but I do think that we've been very open and really forthcoming with the fact that we needed to meet and we needed to make some accommodations at times of saying one person only. If that person were to leave, then there's no one. That just didn't feel like the right thing in our population specifically. So I think that there were times that we stumbled, and I think we made mistakes along the way, and we did our best to remedy that and do a better job the next time around. So, but I do think that shared decision-making is we're having this discussion is really the important thing, and that the person, especially on the provider in the inpatient setting, that we're listening, not listening with an intent for an answer, but listening for an intent to meet the needs of the patients.
Thank you for sharing that, Sarah. There's a lot of great conversation happening in the chat. I just want to call people's attention to that. Thank you, Dr. Jali. So I think as we are kind of having this conversation, I'm going to do one more quick round. If anyone wants to jump in or has anything to say before I move us to the call to action. Okay.
This is just a quick, and sorry, this is Chloe again. Just a quick comment that I think maybe we didn't make explicit, but as we're building policies, I think the goal for all of us as clinicians should be to incorporate lived experience into any sort of implementation, right? Like that should just be the basic assumption that patient experience and patient voices are going to be heard as we develop the policies, not just in reaction to the policies, but I think to get to a place where we could incorporate patient experience, patient preference, patient voice into the way we develop and implement all of our policies and programs would be the ideal. Certainly what we're trying to get to within Penguin.
Thank you, Chloe. Okay. So we have a call to action to kind of close us out here. And thank you all for allowing me to be your MC for this past hour and some change. How are you all, and you can take yourself off mute or you can write it in the chat. How are you all going to take action this week to center the voices and experiences of birthing people and families? So it could be continuing great business as usual and some of the things we've talked about in the chat that are working well. It could be taking some of the feedback that you've heard here today and revising and incorporating some of your policies, hard or soft policies in the hospital, labor and delivery. It could be having conversations that are centered and compassionate and really prioritizing your birthing people's experiences and giving them what they need. But how are you going to take action this week to center the voices and experiences of birthing people and their families? And that's an open conversation. Thanks. And with that, our formal agenda has adjourned. Thank you.